Hello and welcome to the topic Non-Alcoholic Fatty Liver Disease or NAFLD in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define non-alcoholic fatty liver disease, discuss the pathophysiology of non-alcoholic fatty liver disease, explain the clinical presentation of non-alcoholic fatty liver disease, outline the investigations, the diagnosis of non-alcoholic fatty liver disease, and finally, discuss the management of non-alcoholic fatty liver disease. Let's get started. Non-alcoholic fatty liver disease or NAFLD is a very common disorder and refers to a group of conditions where there is accumulation of excess fat in the liver of people who consume little or no alcohol. Compared with a normal liver, which is on the left, a fatty liver appears enlarged and discolored. Tissue samples reveal fat deposits in non-alcoholic fatty liver disease, while inflammation and advanced scarring are visible in non-alcoholic steatohepatitis. An abnormal accumulation of fat in the liver in the absence of secondary causes of fatty liver, such as significant alcohol use, viral hepatitis, or medications that can induce fatty liver, characterizes non-alcoholic fatty liver disease. The term NAFLD encompasses a continuum of liver abnormalities from non-alcoholic fatty liver, which is simple steatosis, to non-alcoholic steatohepatitis or NASH. Microscopic view of a healthy liver and a non-alcoholic fatty liver will tell us the difference. Causes of fatty liver disease may include eating excess calories, which causes fat to build up in the liver. When the liver does not process and break down fats as it normally should, too much fat will accumulate, and people tend to develop fatty liver if they have certain other conditions such as obesity, diabetes, or high triglyceride levels. According to the evidence from relevant studies, the gut microbiota may contribute to the pathogenesis of NAFLD through several mechanisms, including number 1, increased production and absorption of gut short-chain fatty acids. Number 2, altered dietary choline metabolism of the microbiota. And number 3, altered bile acid pools. The clinical syndrome of NAFLD spans from bland steatosis to steatohepatitis, which can progress to fibrosis and cirrhosis. The pathogenesis includes roles of hormones, nutritional and intestinal dysbiosis, insulin resistance, lipotoxicity, and hepatic inflammation, and these are the genes that are examined. So what are the 3 causes of NAFLD? Number 1 being obese or overweight, number 2 having type 2 diabetes, number 3 having high blood pressure, and number 4 having high triglyceride levels. Symptoms of non-alcoholic fatty liver disease include having pain or discomfort in the upper right abdomen, extreme tiredness, unexplained weight loss, weakness, chronic fatigue, nausea or vomiting, and also sometimes weight loss. As for the signs, you may appreciate all the chronic liver disease signs or signs of liver cirrhosis in a patient with NAFLD. There might be jaundice, ascites, lower limb edema, dark urine or pale-colored stool, web-like clusters of blood vessels under the skin, which is spider angiomatas, splenomegaly, and many more. So patients with NAFLD are often obese and may have hypertension. The most frequent signs or symptoms that are appreciated would be mild to moderate hepatomegaly. When it comes to laboratory tests, focus on blood tests which are useful to confirm the diagnosis or rule out other pathologies. Examples of tests that can be carried out include ESR, a glucose level, serum albumin levels, kidney function tests, coagulation profile, a viral serology panel, serum biomarkers, as well as not forgettingly liver enzymes. Results are elevated alanine transaminase and aspartate transaminase, usually 1 to 4 times the upper limits of normal. A liver ultrasound or magnetic resonance imaging MRI can diagnose steatosis but not fibrosis, and confirmation of early cirrhosis detection by ultrasound or by other diagnostic methods is recommended. CT scan, or also formerly known as an computed axial tomography, is a medical imaging technique used to look at detailed images of the body non-invasively. So here, what's important is that they are useful in establishing the diagnosis of steatosis, in finding evidence for portal hypertension, as well as helpful in ruling out biliary dilatation or choledocholytisis in patients with cholestatic pattern of liver test results being abnormal. NAFL warrants treatment regardless of whether the affected person is overweight or not. Weight loss is the most effective treatment for NAFL. A loss of 4% to 10% body weight is recommended, with 10% to 40% weight loss completely reversing NASH without cirrhosis. A structured weight loss program helps people with NAFL lose more weight compared with advice alone. A combination of improved diet and exercise rather than either alone appears to best help manage NAFL and reduce insulin resistance. Motivational support such as cognitive behavioral therapy is useful, as most people with NAFL do not perceive their condition as a disease and thus have low motivation to change. For severely obese individuals with NAFL or NASH, bariatric surgery improves or cures the liver disease if there is no cirrhosis or liver cancer. Bariatric surgery is an effective method for obese and diabetic individuals with NAFL to induce weight loss and to reduce or resolve NASH inflammation, including fibrosis, and this helps improve longevity. Next would be liver biopsy and histopathologic examination. Well, this is part of a surgical intervention as biopsy is invasive. These are important components of a diagnostic evaluation in patients with suspected alcoholic liver disease. They are more sensitive and specific means of evaluating the degree of liver cell injury and hepatic fibrosis. So here, it's justified to obtain a liver biopsy in patients which help confirm the diagnosis, exclude other unsuspected causes of liver disease, assess the extent of liver damage, as well as defining the prognosis. Last but not least, let's take a look at complications and prevention of this condition. Cirrhosis, which is a main complication of NAFLD, is a late-stage scarring in the liver. Cirrhosis occurs in response to liver injury such as inflammation in NASH. As the liver tries to halt inflammation, it produces areas of scarring or fibrosis. With continued inflammation, fibrosis spreads to take up more and more liver tissue. If the process isn't interrupted, cirrhosis can lead to ascites, hepatic encephalopathy, as well as end-stage liver failure, not forgettingly, liver cancer. To reduce one's risk of having NAFL, choose a healthy diet, which is a healthy plant-based diet that's rich in fruits, vegetables, whole grains, and healthy fats. Maintain a healthy weight. So if one is overweight or obese, reduce the number of calories one eats each day and get more exercise. Exercising most days of the week is extremely useful in reducing visceral deposition of fats. In summary, we have looked at the definition of non-alcoholic fatty liver disease, which is basically the accumulation of liver fat not caused by any other reasons such as medications, drugs, or alcohol. We have seen the pathophysiology and causes and the clinical manifestations. We have also looked at the investigations that can be useful in diagnosing non-alcoholic fatty liver disease as well as excluding other possible differential diagnosis. We have also looked at the medical and surgical aspects of management in non-alcoholic fatty liver disease, and lastly, the complications and prevention for this condition. We have come to the end of this topic. Thank you for your time.